Hello, and welcome to the Intro to Likelihood Ratios podcast. I'll be your presenter, Justin Adam. So to start off, I'd like to think about a question. What is our goal when we evaluate a patient's symptoms or complaints? Given this is a somewhat rhetorical question, I thought we would just start off by taking a few seconds to think about this. What I would like to argue is that the goal is to determine whether the patient does or does not have a disease. Now, if you're a pathologist, this is a relatively easy task for you to do. You have all of the pertinent history, you have all the labs, you have some sort of tissue in which you're evaluating to help you make this diagnosis. However, as internists, we are trying to determine how likely it is that a patient has a disease, or essentially what is the probability that a patient has the disease. And therefore, based off of that probability, determine whether treatment is necessary for this condition. So to start off, let's think about a case example. So this is a 60-year-old male who presents to the ED with acute onset of sharp pleuritic chest pain and hemoptysis. He's tachycardic to 120. He has a past medical history of adenocarcinoma of the lung, and he's undergoing active treatment. Plus, he has a prior history of a PE. So what I would like to do is then walk through what is our thought process. Essentially, what is our diagnostic reasoning as we're thinking about this patient. So to start off, what diagnosis are you concerned about? Hopefully, after hearing the case and hearing the presentation, the most likely diagnosis you would be concerned about would be a pulmonary embolism. The next step is to think about how likely is it that the patient has a PE, or what is the probability that this patient has a PE? Now, this could be anything of your choosing, whether this is 25%, 50%, 75%. And I recognize as physicians, we hate to be pinned down on a number, whether how soon this patient should be discharged, when the test is going to come back, things like that. However, to really work through this process, we have to pin ourselves down to a pre-test probability. The next step is, what is your threshold for treatment? So at what level are you confident enough that this patient warrants treatment, and at what level are you confident enough that this patient does not have the disease and therefore does not warrant treatment? This can be, again, kind of thresholds that you'll set for yourself, but you do have to pin yourself down on a hard number. So for instance, in this case, let's say if it's less than 5%, I'm sure enough this patient does not have a PE and I don't need to treat. And if it's greater than 90%, I would feel confident enough that this patient does have a PE and therefore warrants treatment. The last step is to determine, depending on what that pre-test probability is, do I need other tests to get me above or below those thresholds? So to get me above 90% or below 5% that I feel confident enough that this patient either does or does not have the disease. So to walk through these steps individually, I'll talk about some tools that we have at our disposal to work through this. So to start off with our pretest probability, or how likely it is that a patient has the disease, the first thing that we have at our disposal is our clinical judgment. So this is the gestalt that we have after getting the patient's history, doing physical exam, and looking at whatever laboratory studies we have at that point in time. The next part of it is clinical prediction rules. So these are tools that have been created that help to determine pretest probabilities of a disease before ordering future tests. I chose some examples here. So for pulmonary embolism, there's the Wells criteria. For coronary artery disease, there's the Diamond-Forrester or the CAD consortium calculator. Strep pharyngitis, there's the Centaur criteria. And for HIT, there's the HIT pretest probability score. These will all give you a certain pretest probability after you've put in certain clinical variables and other physical symptoms and signs. If you have nothing else after your clinical judgment and your clinical prediction rules, you can base the prevalence of the diseases and set that as your pretest probability. So now that you have your pretest probability, the next part is to determine what are your thresholds for treating versus not treating. So for the upper limit, this will be some preset number in which you choose that above this threshold you feel confident enough that this patient does have the disease and therefore would warrant treatment. So in this case example, if there was a probability of 95%, you would feel confident enough that this patient does have the disease and therefore would warrant treatment. On the lower limit, this is a preset probability that you determine by yourself, that below this you feel confident enough that the patient does not have the disease and therefore does not warrant treatment. If you find yourself in the middle, this is a place in which you need more information. You need more diagnostic studies, you need more history, you need more laboratory studies, whatever it is. But you need more information to either get you above your treatment threshold or below your do not treat threshold. So important thing to take into account is that our treatment thresholds depend on two variables. The first one is the severity of the disease. So diseases with high morbidity and mortality will tend to have a lower no treatment threshold. To think about this, you want to be really sure that a patient does not have a disease in which there would be high morbidity and mortality. So example that we were talking about from before is pulmonary embolism. So you may set your lower no treatment threshold around 5%, 2%, something like that, because you know that if you miss something like a pulmonary embolism, there is the chance for high morbidity and mortality. The other thing to take into account is the toxicity of your treatment. So treatments with higher toxicity will tend to have a higher treatment threshold. So the example here would be cyclophosphamide for lupus nephritis. So you would want to be very, very sure that this patient has lupus nephritis before you would start something like cyclophosphamide, which has a high toxicity. So therefore, you may pursue something like a kidney biopsy to make sure that you have a high enough post-test probability that you feel absolutely sure that this patient does have lupus nephritis before starting something like cyclophosphamide. So if you find yourself in the middle and you need more diagnostic information, how do you determine what is the best or most useful diagnostic test? So historically, we've been taught to use sensitivity and specificity for a test. And maybe one step above that, maybe using positive predictive value and negative predictive value. However, to use these appropriately, we need to take into account the prevalence of the disease. What I would like to argue is that likelihood ratios are a better test to determine what would be the utility of that diagnostic test. And what's nice about likelihood ratios is they do not need the prevalence of the disease because they're based on the sensitivity and specificity, as we'll see here in a little bit. What are likelihood ratios? So a likelihood ratio is the probability of an individual with the condition having a certain test result compared to the probability of an individual without the disease having a certain test result. So essentially this makes a proportion of which the patients with the disease are on the top and patients without the disease are on the bottom. The thing to keep into account is that this will be different based off of if there's a positive test result or if there's a negative test result. So therefore there will be separate positive and negative likelihood ratios for each test. And the one thing to keep in mind is that this is for tests in which they are bimodal, in which they just have a positive result and a negative result. There are likelihood ratios for other tests in which there are multiple results which could happen, but what we will focus on today is positive and negative results. So how are likelihood ratios calculated? So a positive likelihood ratio equals the sensitivity over 1 minus the specificity. And a negative likelihood ratio is 1 minus the sensitivity over the specificity. Circling back to what we've talked about thus far, what I would argue is that we do 3 important steps to consider when ordering a test. We need to determine what is the pretest probability of the disease, which we can use our clinical judgment, clinical prediction rules, as well as the prevalence of the disease. The second test would be to determine what your treatment thresholds are for either treating versus not treating. And if you find yourself in the middle, determining the likelihood ratio of the test that you are about to order. So let's walk through a quick example. So determine the pretest probability of the disease. Say for this example, the pretest probability is 50%. The next step is to determine what are the thresholds for treating versus not treating. So again, for this example, let's just say if it's greater than 80%, we feel confident enough that the patient has the disease and therefore we would treat. And if the post-test probability is less than 20%, we would say that the patient does not have the disease and therefore no treatment is warranted. And since we are at 50%, we are between our treatment thresholds, and therefore we need more information, so we will calculate the likelihood ratio of some test. So let's say we're looking at a test that has a sensitivity of 70% and a specificity of 90%. So if you put that into your positive likelihood ratio of sensitivity over 1 minus the specificity, you would land up with a positive likelihood ratio of 7. The same thing for the negative likelihood ratio, 1 minus the sensitivity over the specificity. When you work through those calculations, you end up with a negative likelihood ratio of 0.33. Now, what I would like to do is introduce you to Fagan's nomogram. What Fagan's nomogram has done is they've taken a lot of complicated math and they've truncated it down into a nice, usable nomogram in which if you know your pre-test probability and you know the likelihood ratio of the test that you're about to order, you can determine a post-test probability. So, walking through our example, we started off with a pre-test probability of 50%. and we saw that based off of the sensitivity and specificity of our test, we had a positive likelihood ratio of 7. So if we had a pretest probability of 50%, what you would do is then draw a line through 7, which is your positive likelihood ratio, and that would give you your post-test probability. And how this looks graphically would be something like this. So therefore, if you did this test and it was positive, you would have a post-test probability of 88%. The same thing goes for the negative likelihood ratio. So again, you would start with your same pretest probability of 50%, and in this case we had a negative likelihood ratio of 0.33. So you draw a line through 0.33, and this would give you your post-test probability. This graphically would look like this. So 50%, draw through a negative likelihood ratio of 0.33. So therefore, if you had a negative test result for this study, you would end up with a post-test probability of 22%. So with all of this in mind, let's use this in the example of our case from before. So we had a 60-year-old male who presented to the ED with acute onset sharp pilotic chest pain and hemoptysis. He's tachycardic to 120, he has a past medical history of adenocarcinoma of the lung undergoing active treatment, and he has a prior history of a PE. So the first step would be, what is his pretest probability of a PE? What's nice in this case is we do have a clinical prediction rule, and that would be the Wells score for pulmonary embolism. So based off of his heart rate of greater than 100, the fact that he has a malignancy, hemoptysis, and we think that PE is the most likely diagnosis, he would have a Wells score of 6.5. This would put him into the high-risk group for the Wells score, and therefore would put him at a 37.5 pretest probability of having a pulmonary embolism. So the next step that we need to do is determine what our treatment thresholds would be. So we are sitting here at a pretest probability of 37.5, and we need to say, at what level do I feel confident enough that this patient has a PE and therefore warrants treatment and anticoagulation, and at what level do I feel confident enough that this patient does not have the disease and therefore does not have a PE and does not warrant treatment. So just for example here, I chose the cutoffs and thresholds of 90% for the treatment threshold and 5% for the no treat threshold. So if the post-test probability is greater than 90%, I would feel confident enough that they have a PE and we should anticoagulate the patient. And if the post-test probability is less than 5%, I feel confident enough that this patient does not have a PE and therefore does not warrant treatment. So now that we have our pretest probability and we have our thresholds, we need to think about what test we would order to help us get above or below those thresholds. So one of them would be a D-dimer, which has a positive likelihood ratio of 1.72 and a negative likelihood ratio of 0.2. The other test that we probably have at our disposal is a PE protocol CT, which has a positive likelihood ratio of 24.1 and a negative likelihood ratio of 0.11. You could argue for some of the other tests which are listed here, but we'll focus on these two examples as we walk through the case. So using your D-dimer, we started with a pretest probability of 37.5. And so let's say if we ordered a D-dimer and we ended up with a positive result. So it had a positive likelihood ratio of 1.7. So when you draw that out, you would have a post-test probability of around 47%. Let's think about a negative result. So here we started off with 37.5 for our pretest probability. It has a negative likelihood ratio of 0.2, so therefore we would end up with a post-test probability of 10%. So as you can see, when ordering a D-dimer, whether it's positive or whether it would be negative, we still find ourselves in this intermediate probability in which we're not sure enough that the patient either has a PE or does not have a PE, and more tests would need to be ordered. How about a PE protocol CT? So again, starting with our pretest probability of 37.5, let's say we got a positive result for our PE protocol CT. So this had a positive likelihood ratio of 24. So therefore, if the results were positive, this would put us at a post-test probability of 94%. This would be above our treatment threshold of 90, so we would feel confident enough that this patient does have a PE and would warrant treatment. How about a negative result? So it had a negative likelihood ratio of 0.1, and so therefore you would have a post-test probability of around 4.5% if there was a negative result for your PE protocol CT. Therefore, this would be low enough that we would feel confident that this patient does not have a PE and no treatment would be warranted. So how can I use likelihood ratios from day to day? The first piece that I think what we can use them is to determine a post-test probability of a disease after we have ordered a test. So we know that it's positive, we know that it's negative, we can look up what the likelihood ratio of that test would be, and based off of what our pre-test probability was, we can determine what the post-test probability of the disease is. The second way in which we can use likelihood ratios is to determine the utility of a test before we actually order it. So we can come up with whatever our pre-test probability would be. We would look up the likelihood ratios of the proposed test that we are going to order, and we'd run them through to see if there was a positive or negative result, to see if it would get us out of that intermediate zone. If after a positive or negative result, if we're still in that intermediate zone, we may want to rethink the test that we would be ordering because more tests would be needed in the future, and this may not necessarily be the best test at that time. The last way that I think we can use likelihood ratios is teaching diagnostic reasoning to our students. So if you think about our last example with the pulmonary embolism, we had a high pretest probability of PE before going into ordering our test. And as we saw with the D-dimer, whether the D-dimer was positive or whether the D-dimer was negative, we were still in that intermediate zone, and therefore more testing would be needed. So this is a way to teach to our medical students that if you have a high pretest probability, there's no diagnostic utility of using a D-dimer, because whether it's positive or whether it's negative, it does not help us. And therefore, if we have a high pretest probability of a PE, that we should just go ahead and order some sort of imaging study, whether that's a VQ scan or whether that's a PE protocol CT, because that will lead us to having a high enough treatment threshold to either treat or to not treat. So that's another way in which we can use this, is to teach diagnostic reasoning to our students. So how can we apply likelihood ratios at the bedside? So hopefully, either through academic half day or through other means, you've been able to pick up a pocket card which has a Fagan's nomogram on it, as well as the equations for a positive and negative likelihood ratio. If you have not received these, please email me and we will get those pocket cards to you. The next way is that there are some pretty great apps which are out there. So on the iPhone, there's an app which is called DocNomo, which is free, and this has a digital Fagan's nomogram. So if you don't want to carry the pocket card around, there's another way that you can use this as well. And then there's also an app which is called EBM Tools, which is again free, and this has a simple calculator for likelihood ratios using sensitivity and specificity. If you're like me and you don't have an iPhone, for the Android devices there's an app which is called Diagnose, which is also free, and this has kind of a master database of likelihood ratios for common diseases, including things like physical exam findings, etc. This is also open for Apple, but this is really the only one that's there for Android. If you're lucky enough to be by a computer, you can pull up the web address lrdatabase.com. This is a large database of many different likelihood ratios, and you can use that as well while using your Fagan's nomogram to figure out what your post-test probabilities would be. So that is all that I have. Hopefully, up until now, I've convinced you that likelihood ratios are awesome and that we should be using them more than what we currently are. If you have any questions up until this point, please shoot me an email at juadams@mcw.edu, and I'll be happy to get back to you. Hopefully in the next couple of months we'll be using likelihood ratios more at noon reports to get you more familiar and more comfortable using them, and then hopefully we'll be using them at the bedside as well as to teach our students about diagnostic reasoning. Thank you for your time.